This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Hey everybody, welcome back to Soundcheck, the monthly POCUS QA and education podcast from MedStar emergency physicians. Today, we're reviewing 5 great bedside ultrasound cases, starting with a soft tissue scan that helps separate abscess from cellulitis and avoids vascular mimics like pseudoaneurysm. Then we'll move into a dramatic cardiac tamponade case in PEA arrest, where bedside ultrasound identified the cause and directly led to a pericardiocentesis performed by the ED team that saved the patient's life. We'll also cover a bubble study showing shunt physiology, a molar pregnancy diagnosed on transvaginal ultrasound, and finally a ruptured ectopic pregnancy with free fluid and fetal cardiac activity outside the uterus. These cases highlight how POCUS can sharpen diagnosis, guide procedures, and sometimes completely change a patient's course in real time. As always, I'm joined by one of my excellent co-hosts from the MedStar Georgetown and Washington Hospital Center Emergency Medicine Residency Program. This month, I'm joined by Dr. Jon Giolitti. Jon, thanks for joining me.
Happy to be here.
All right, you ready to get into these cases?
Let's do it.
So case 1 we have is a man in his 50s who came to the emergency department for some redness and warmth over his left antecubital fossa. Okay. And we are going to look at an ultrasound evaluation of that area. He was overall afebrile and well-appearing, but the ED team was concerned for cellulitis or abscess or some other vascular complication. So walk us through this ultrasound. What probe are they using? Why do you think they chose this probe specifically?
It looks like a linear probe to me. I think they probably did this because of the concern for a superficial type finding or infection. So with the linear probe, you get better resolution for the more superficial structures, which seems ideal for this situation.
Yeah, for sure. Remember that just for the listeners, that there's a trade-off between your depth of penetration with the ultrasound waves and the resolution. So we have this structure here between the skin and about 2 centimeters down. How did you describe that in ultrasound terms?
Sure. Looks like a heterogeneous kind of mixture of stuff in there. More superficial, seems more anechoic, and then as you get a little bit deeper, like close to the 2 centimeter mark, it becomes more hypoechoic, especially compared to everything else.
Yeah, so some of this anechoic stuff up here you're referring to, right?
Yep.
And then mixed ecotexture, kind of debris looking stuff there.
Yep.
All right, so let's go on to the next view. This is maybe in the same axis, maybe they turn. Sometimes it's usually good to get in multiple, like a longitudinal and a transverse axis, but can you tell what they're doing here? It looks like there's some movement.
Yeah, it looks like they're pushing down on this area, like with the probe.
Yeah, so what are they finding? Why do you think they're doing that?
I think they're trying to see if they can manipulate whatever is contained within this area that we're looking at.
Yeah.
And it looks like in this situation they can.
Yeah, it looks like it's moving almost like peristalsing.
Yeah.
So it's a gross term, but for this one they call pusstalsis because it looks like you have the bowel peristalsis here with the downward pressure of the probe. So you can see it swirling there.
I can buy that.
It's a nasty term, but that's what it is. So now you see that they have a color Doppler box on it, right?
Yep.
So what's the utility of doing this, and are we seeing anything notable?
I don't think I'm seeing anything notable. I think that we want to do this to make sure that there is no vascular flow contained within this area that we're looking at for supposed possible abscess. And in this case, I don't see anything that would make me think that.
Yeah, so we are seeing some signal, right? Some of this, I'm not sure if this is artifact down here or not, but there's definitely some pulsatility right around here, but there's nothing within this cavity itself.
Correct.
The biggest thing that we would get concerned about that you are accidentally going to cut into some pseudoaneurysm or something, because they can look fairly similar and red and swollen. So in that case, you'd see usually a Doppler signal within this fluid collection, often swirling, and you see something called the yin-yang sign. So let's take a look at an example of a pseudoaneurysm to compare. So this patient is getting an evaluation of some wrist swelling, and you can see the Doppler findings here that we don't want to see when we're evaluating an abscess is this thing called a yin-yang sign. So you see bidirectional flow within this like aneurysm, pseudoaneurysm stalk. This is all clotted hematoma within the pseudoaneurysm. And you see this looks like the Chinese yin yang here. So that means that there's flow going one direction in part of this area and then flow going the other direction. Do you remember what red means and what blue means here?
Yeah, so red refers to flow coming towards you or towards the probe versus blue, which represents flow away from the probe.
So how can you remember that
There's a great mnemonic I learned called BART, like from The Simpsons, and BA being blue away, and then RT being red towards.
Yep, so that's if you are mnemonic lever, you can use that, or you can just look at this key here as well. So this is referring to the velocity of flow, and the red is a positive velocity, 4.8 maximum centimeters per second, or a negative flow here, negative velocity is the blue. So if a positive flow, it means it's going towards your probe, which is up here, and you have a positive velocity going towards it. If the velocity is negative, that means it's going away from you. All right, so that is pseudoaneurysm. This is something you definitely would not want to cut. And then let's contrast that as well to another finding that you could see in this concern for skin infection is just cellulitis. So what's the ultrasound term or the finding that you're seeing here that's abnormal?
It looks like something called cobblestoning.
Yeah, so this is cobblestoning here. I just want to orient everybody that this is not a fluid collection. This here is this is the foot. So this is the dorsalis pedis artery here. But all the soft tissue around it is what we want to focus on. And you see how you have these lobules here that are separated by this subcutaneous edema. So this, in contrast to the case that we first saw, is not really something that's drainable, right? This is all kind of third-spaced subcutaneous edema, right? When people have like CHF, you can't just drain their legs because it's all within these like fluid planes within the fascia. So that's an example of just plain old cellulitis. In this case, I don't see any clear fluid collection that you'd want to drain. All right, so we'll go back to our original case here. So it's important that we were applying Doppler before incision, so we're ruling out that we did have a pseudoaneurysm like the other case. We're verifying that we actually have a drainable fluid collection, and this is not just cellulitis. And keep in mind that you can have both, right? You can have overlying cellulitis of a fluid collection, so you just need to scan thoroughly and make sure that you have identified any fluid collection if they're present. So it's important to take this ultrasound survey of the forearm and the antecubital fossa, right, John? Because there's some important structures there, right?
Sure are.
What kind of anatomy would you be looking out for as well?
I definitely get nervous about the nerves that are in there, so especially the median nerve. But then there's also vessels, so brachial artery, and then obviously that bifurcates into the radial and ulnar arteries, so lots of stuff in there.
So this overall, luckily, is fairly superficial, but you're right, there are a lot of, if you're deeper down, you would want to make sure you're not going to directly go into the median nerve, and it usually has that kind of honeycomb appearance of it. That's classically for a nerve. And then this is another reason why you can put on Doppler flow and make sure you're not seeing anything pulsatile that's just a regular artery that you're going to go through. So this one I think is fine to drain for sure. You can usually use your ultrasound to locate the largest pocket and the area of most fluctuance and just incise directly over that. You can use it to mark any and avoid any nearby vessels. And then sometimes if you have a larger or kind of a pocket that you need to get at that is a little bit more tenuous and has some more sensitive anatomy around it, if you wanted to do like an ultrasound guided live evaluation of it, you can do that as well. But most people just typically use ultrasound to mark your area and then do this mostly blind after they've already marked the anatomy. All right, this next case we have is a really cool case and a great save by one of our emergency teams here. It was a man in his 40s who came to the ER with generalized weakness after dialysis. So obviously he had end-stage renal disease and hypertension. But he was initially very stable. He had a heart rate of 70 and blood pressure of 110/69. But then suddenly became very diaphoretic and said, I need help, and then went into sudden PEA arrest. So they were able to get return of spontaneous circulation initially after ACLS measures, but then unfortunately the patient just kept going into recurrent arrest after the epinephrine wore off and was continuously hemodynamically unstable. So they did a bedside ultrasound to evaluate for some of the reversible causes of his PEA arrest. So, Jon, what are some of the reversible causes that we can look for on bedside ultrasound?
Sure. So we could look for a tension pneumothorax. We can look for someone who's like hypovolemic. We can look for pericardial effusion causing tamponade. A PE, obstructive shock.
Yeah. Perfect. So this is a personal long view of this patient during one of the episodes of return of spontaneous circulation that was fairly brief. So can you walk us through what you're seeing here and what sort of abnormal findings they're seeing?
Yeah, this is peristernal long. The first thing that jumps out at me is the effusion. I can see it both anteriorly and posteriorly.
Yep. So we'll pause here for a second just to orient everybody. So just the general anatomy here. We do the ED echo standard generally. So we have the probe marker is on the left side of the screen, and this will be oriented towards the patient's right shoulder. This is the left ventricle here. This is the left atrium, and then this is mitral valve, the aortic outflow tract, and the aorta here, right ventricle, and then you have these fluid collections. Sometimes it's basically circumferential, anterior and posterior. So I'll play it in real time so we can see that. You have this fluid collection here, and then circling back around, you have another fluid collection here. This is like a little bit of the internal echo, the septation within it. So this is all kind of continuous though. All right, so this is concerning for a pericardial effusion for sure, right? So just because they have pericardial effusion, does that mean they have tamponade?
No, not necessarily.
Yeah, because it really matters about their hemodynamic status, right?
Yep.
And how quickly generally this fluid accumulates and how the heart can accommodate, right? Because you can have some dialysis patients that have a liter of fluid and are just walking around and have no symptoms. Or you have a person that, for instance, young, healthy person with a normal heart, they get stabbed and they have a few cc's of blood in their pericardium and they are very unstable. So really the timing makes all the difference. And there's some findings on echocardiogram that we are going to look for to determine if they're having any hemodynamic change. This patient's in arrest, so I'd probably assume that this is the cause of their arrest until proven otherwise, but there are some other findings that we're seeing here. What about the right ventricle do you see?
Looks pretty small to me.
Yeah, so right ventricle, generally always smaller than the left ventricle, but it does look small and probably underfilled. And looks like some weird motion of this free wall, this anterior right ventricular free wall.
Yeah, I can see that.
Kind of looks like it's bowing in a little bit here. And that's different than the D sign that you think of, right? That's the septum bowing, but this free wall is what looks like this has this abnormal motion. We'll see some other pictures of it. And that's because you're having these pressure-related changes from this fluid in the pericardium that's pushing on the right ventricle. And the right side of the heart's more susceptible to these pressure changes just because it's smaller and not as robust as the left ventricle, right?
Okay.
So then we'll look at, now we're in a peristernal short. This is a little bit of a limited view here, and I think we'll see a little bit better one later, so we'll skip that for now. And then I believe this is probably a subxiphoid view now, so you can see, again, that fluid collection. If we stop and measure it, it is at the maximum here, probably, it's almost 3 centimeters deep. So this is not an insignificant amount of fluid there. All right, and then again, the big thing that you want to look for are these right-sided pressure changes. So the big things that you'd want to look for is this right ventricular diastolic collapse. So during diastole, the heart should be filling and getting larger, but because of the paradoxical physiology in tamponade, the right ventricle starts getting smaller and starts to collapse during diastole. If you're able to see the right atrium, you can also see right atrial systolic collapse, usually because it's the opposite filling cycle as the ventricle. And then here, we're not going to look at the IVC, but what would you expect typically of the IVC in a tamponade patient?
I expect it to be pretty big or plethoric since the blood's not able to fill the right ventricle.
Yeah, this is called, what kind of shock?
This would be like an obstructive shock.
Obstructive shock, so it can't fill, and you get all the blood from the legs really can't get into the heart because of this external pressure that's forcing upon the heart. Here's another example of, this is a subxiphoid. You can see the liver here, and this right ventricular free wall abnormal motion. So there are some other kind of fancy calculations and things that you can do for tamponade, and we've gone through some of those in the other videos if you want to check the playlist. But in this situation, you have a person that's in cardiac arrest and you see this. What do?
Pericardiocentesis.
You got to relieve this obstruction, right? They're basically dead, right?
Yeah.
So you have very little to lose and a lot to gain. So that's exactly what our emergency medicine team did at the bedside after seeing this echocardiogram. So this is just another view of the peristernal short that we didn't get before. You can see the right ventricle is almost not even there, right? This is still pre-procedure. The left ventricle is still a little bit underfilled. It's a small LV cavity, and that's just showing how the heart can't fill because of this obstructive shock.
Mm-hmm.
So let's talk about pericardiocentesis then.
Okay.
So we've identified that there's a fluid pocket,
Yep.
and you'd want to use ultrasound guidance, generally doing it. Formerly, people would do it blind, right? Just like a landmark approach, but that seems nerve-wracking to me, and we have an ultrasound on their chest already, so we should use it just to be safe.
Yeah.
So there are a couple of different approaches that you can use. There's a peristernal long approach, which we'll talk about primarily, but then you can also approach it from the subxiphoid, even though you do have to go through the liver to get there with your needle, or sometimes you could do apical 4 as well. But I think the peristernal long is probably the safest and easiest approach if we're just going to talk about one. And you can use a kit that's designed for this, or the simplest and fastest way is just use a spinal needle on a syringe and aspirate some of this fluid out to see how that affects your hemodynamics. So right now we're using a phased array probe, right, John?
Yep.
So would you want to use that one to do the procedure if you had a choice?
Probably not, actually.
Yeah.
Since we're just going for that fluid pocket that's anterior, we can zoom in a lot, and if we can get better resolution with a linear probe, I think that would be best in this situation.
Yeah, I think you're right for sure. And then you can get really good needle tracking through this area, right? This wouldn't be optimized right now because you're trying to take a needle from the skin to right here, and you want to make sure that you're not going too far, right? And that you're in the correct axis. So the superficial is usually best for procedural guidance like that. What are some of the structures in the chest wall and around the ribs and stuff that you want to avoid anatomically?
Specific to the ribs, there's the neurovascular bundle that runs under the rib. So you'll want to avoid like the inferior part of ribs. In the chest wall, you have the mammary vessels or arteries. So those would be of risk.
Yep. So just knowing where those are anatomically, and also you can put color flow on them.
True.
If you're using the linear probe, you just put like Doppler over the skin and just make sure you're not about to transect the internal mammary artery if you can avoid it. So in this case, they did exactly that, a peristernal long needle ultrasound guided pericardiocentesis. They were able to get 50 cc's of bloody fluid that was removed, and the patient had an improvement in his hemodynamics, and then was able to be stabilized, was on some vasoactive drips for a little bit. They had a drain placed after that for a few days, and then extubated after 2 days, and then left the hospital neurologically intact, walking, no issues, 1 week later.
It's awesome.
Okay, this next case was a guy in his 70s who was found at home by a home health aide who had severe tachycardia, hypotension, and just basically poor functional status and kind of failure to thrive. His initial vitals were a heart rate of 208, obviously very fast, and a blood pressure of 85/50. So while they were trying to resuscitate him, they did a bedside echocardiogram. And this is not going to be a full echocardiogram, just has an interesting finding and technique that we can talk a little bit about. So first off, just looking at this heart, we can tell that it's fast, right? Or even from his vitals, but the ventricles are beating fast. What do you think about the atria?
Pretty big.
They're very large atria. If you had to guess what rhythm he's in, basically with big atria and a really rapid ventricular rate, what would you expect?
I would probably guess like AFib RVR.
Yeah, I think that's probably right because it looks somewhat irregular, I guess, of the ventricle, and then having these atria being very enlarged with the atrial stretch gives you increased risk for atrial fibrillation.
Makes sense.
So then this ultrasonographer did what's called a bubble study. So we'll see that here. And if you look focus your attention on the right atrium, obviously you see this mixing and this hyperechoic, these bubbles that are appearing in the right atrial chamber. So the technique to do this is that you take a very small amount of air into a syringe, a saline syringe, very small amount because you don't want to obviously give them an air embolism, and then you shake it up and squirt out any extra like kind of free air that you have in the syringe, and then inject that back in the IV. And those small little microbubbles are what you're seeing appear on the screen here in the right atrium. So generally, these from the right atrium then go to the right ventricle and then get put in the pulmonary circulation before they return to the left side of the heart. So there's a couple reasons why you could have a few bubbles show up in the left side of the heart when normally they're filtered out. So you can have some sort of shunt, right? So what are some anatomic variants that you can have in the atria that could cause that? There's two.
You could have like a PFO, I think it's patent foraminovalle, and then some sort of other like atrial septal defect.
So some sort of abnormal anatomic connection between these two atria. So, and then the other reason that you could do that is that you have some sort of intrapulmonary shunt, right? That for some reason this blood is not going through the normal capillary beds that filter these microbubbles out. And then if you do have that, typically you'll see this delayed, right? Because it's going to take some time for that blood flow to get through the lungs and then return. So if you have appearance of bubbles within the first 1 to 3 beats, generally, that's usually indicative of some sort of intracardiac shunt. Versus a little later than that, you'll have some sort of intrapulmonary shunt. So in this case, if you look at you direct your attention to the left atrium here, you can see within the first couple of beats, you get these scattered little air bubbles that are appearing here. It's obviously not as dramatic here, but you can see probably 5 or 6 that are showing up initially, and then a couple more up here if we let this play for a second. So this is likely indicative of some sort of intracardiac shunt. Some of the applications of why you may do this bubble study are that you have a patient with undifferentiated or unexplained hypoxia. That could be a cause of it. If you're doing a stroke workup or evaluating for a PFO, as you said. Okay, next patient we have is a woman in her 20s who came to the emergency department saying that she was around 8 weeks pregnant. She was experiencing some vaginal bleeding and had not received any prior obstetric care so far, but she did have a pregnancy test at home about 1 month ago. So she came in for this bleeding. They did do a urine test and a blood quantitative test that revealed a beta HCG of 137,000, with her saying she's about 8 weeks by dates. So a ultrasound was done here. So it shows this is a transvaginal ultrasound, right, John? Yeah. So that means probably did a transabdominal ultrasound, but weren't able to clearly see an intrauterine pregnancy. So sometimes when that's the case, you want to switch to transvaginal, you can get much better resolution.
Makes sense.
So this is a longitudinal view of the uterus, and the technique for this one is that you would insert the probe and you have the probe indicator pointing up. Your thumb, generally if you're holding it in a full overhand grip, your thumb's basically going to be pointing up. And then to switch to the transverse view, turn your hand towards your left or counterclockwise, and then you'd fan up and down. So here is the longitudinal view. What are you seeing here? You see IUP?
No. I see uterus, but...
Yeah. So there's uterus here. I'll outline it.
I see uterus and something.
Yeah, uterus and something. So uterus and some fluid. We'll look at the transverse. I think it looks a little bit better. You see this kind of irregular mass.
Yeah.
Kind of heterogeneous in here. Some fluid, some kind of hypoechoic areas, some cysts within it, right?
Yeah, there's a lot going on.
Yeah. Could I convince you this looks like a cluster of grapes?
I'd buy that. Yeah.
How about snowstorm?
I like the grapes.
Yeah. So this pathology that we're going to talk about is classically described on ultrasound as a cluster of grapes or snowstorm appearance. Honestly, I've never really bought the snowstorm appearance, but what pathology are we talking about here, John, that we're seeing?
We are talking about here we go. I'm going to laugh, sorry. We are talking about a hydatidiform.
Yeah, it's a hydatidiform mole.
I
But to
like
make it
molar
easy,
pregnancy.
yeah, we'll say molar pregnancy.
There we
Very
go.
hard to say. Hydatidiform mole. So this is an abnormal pregnancy, right? This is not your standard run-of-the-mill IUP.
No.
Do you remember why you get a molar pregnancy? What happens, like, I guess, embryologically or whatever to create this?
I believe that you have essentially like empty egg cell that gets fertilized by sperm. From a genetic standpoint, it's only like the paternal genome that's involved here.
And besides you just not having a normal developing pregnancy, why is this important to recognize?
For sure. So you get something called like this trophoblastic proliferation, and this can be dangerous for mom. Obviously there's no fetus here, but it does increase your risk for cancers and other dangerous things downstream.
Exactly, yeah. This trophoblastic disease is it can be a pre-malignant condition, can lead to choriocarcinoma, so it needs close follow-up and some additional testing besides this. So the women that are experiencing molar pregnancy, what's kind of the one main symptoms that they often complain of?
I believe like nausea and vomiting.
Yeah, that's kind of classic, but more than just normal morning sickness. And why is that?
Is because of the super elevated beta HCG?
Yep. Yeah, so we talked about in the case presentation that the beta HCG in this case is 137,000 at 8 weeks. So if you've been doing this, that's really high for that gestational age. Usually people that are coming in the first 6 to 8 weeks of pregnancy, we see beta HCGs of 5,000, 10,000 or less. So that's obviously 13 to 15 times higher than the usual levels. And that can cause a lot of the really bad nausea. Similar to like having twin pregnancy where you have higher beta HCG. It's from that trophoblastic tissue that just creates all this HCG and causes the bad nausea.
Makes sense.
What's another kind of classic boards thing that you see a person come in with? She's having palpitations and sweating and stuff like that. Why might you develop that?
It makes me think of like a hyperthyroidism type of thing. So your beta HCG molecularly looks similar to TSH, so it can bind those same receptors and give you similar symptoms of hyperthyroidism.
Yeah, exactly. So we talked about how this is really important to recognize, and this was recognized at the bedside. They call it gynecology, and gynecology is going to do something about it immediately. This is not something that they're going to have them follow up in clinic. So how's this generally managed?
Typically surgically.
Yep. And then it's important that after that, they want to make sure that they have gotten all of that tissue, right? Because this can continue to proliferate and increase your malignancy risk. So it's important that this is downstream from the emergency department, but that you follow these women until the beta HCG goes down fully to zero, that you've fully eliminated all of this abnormal growth.
Makes sense.
So looking at the scan here, we saw the cluster of grapes or the snowstorm appearance here, but we're also evaluating for other things in early pregnancy. So what's the main differential that you'd be looking for if you see abnormal tissue in the uterus?
Yeah, I'd be concerned about like retained products of conception or something like that.
Yeah. Yeah, so that could be another thing on your differential. This kind of does have the classic appearance, but if they did have a miscarriage or recently delivered, and you can have this debris and this abnormal signal within the uterus. But if you see these cluster of grapes, these cystic structures, especially with the really high HCG in early pregnancy, you really have to consider hydatidiform mole. This woman is in her early 20s and came to the emergency department with severe lower abdominal cramping. She didn't have any nausea, vomiting, or diarrhea. Her last menstrual period was 11 days prior. But then they did a pregnancy test, and her beta HCG was 59,000. So what does that tell you, John, based on her having last menstrual period 11 days ago? That's accurate?
No, something's not adding up here.
Something's not adding up, right? That's fairly high that we usually see. More in advanced pregnancy, so who knows? Maybe she's more pregnant than that and had just some spotting or bleeding in the setting of pregnancy 11 days prior, but that math is not mathing very well. Yeah. So we're going to do a bedside ultrasound here. What's kind of jumping out here? What are some of the anatomy that we should see, and what are you actually seeing?
Yeah, I can see the uterus. I see the uterus kind of right in the middle of the screen when it
let's
comes
freeze it
through
here, right here.
Yeah, there it is.
So this is the uterus here.
Yep. And I can see the endometrial stripe in it.
Here.
But what I don't see is anything within the uterus.
Looks fairly empty. There's not even any fluid collection or no findings of a yolk sac for sure, which is the earliest finding of intrauterine pregnancy. What else, just on the still image, do you see around the uterus?
On the topic of fluid, I do see free fluid, but outside of the uterus. So I get posteriorly, anteriorly within that area.
So that's anechoic stuff here. You see, play it in real time, just so now everybody's oriented with what we're looking at. Bunch of free fluid, bowel loops up here that are in some free fluid. And this is not labeled. It's generally helpful just to have your studies labeled so we know exactly what area you're looking at and laterality and things like that. And then we'll look at another view, which is, I guess, more towards the adnexa area, because you can see here, I think this is probably the hip. You see this is bone that shadows behind it, so they're usually focusing on more of the adnexal structures there.
That makes sense.
And then as we scan through, we're seeing the uterus again at the end of the clip here. We see this like heterogeneous stuff here, which may mean that there's probably some blood, right? This is probably not simple fluid. We could concern for this free fluid that may be blood. And sometimes you can have some clotted blood that can have this appearance too. So maybe that's what's going on, but we'll look at some other images.
Okay.
Now it seems like they're focusing on this area that's outside the uterus again, right? Somewhere in the nexa. This is loops of bowel that kind of looks like a head with where you'd measure the biparietal diameter, but I'm sure that's not a fetal head here, but we do see something else within the adnexa here. You see this circular structure, and within it, another circular structure that looks like it's probably some fetal parts.
Yeah.
So what would you be concerned about right now when you see this free fluid and this adnexal mass with a yolk sac plus or minus fetal pole?
Yeah, given a presentation and everything going on, I'm concerned about an ectopic right now, ectopic pregnancy.
Yeah, and specifically a ruptured ectopic with all that blood. So for sure, if it's ruptured, you saw some pelvic free fluid, and then we'll take a look at the right upper quadrant too. So they're looking primarily right now between this interface between the right kidney, and the liver. What's that called?
It's called Morrison's pouch.
Yeah. Do you see any fluid there?
Not in the pouch, no.
No. And then none like back here too. Sometimes you would look above the liver too, underneath diaphragm, fluid can accumulate there. But what's one other area that's not seen here that fluid can commonly accumulate?
We got to take a look at the liver tip.
Yes. All right, so let's look at the liver tip, and then they're looking here. Yeah, you see this down at the caudal end of the liver, you see this anechoic fluid collection. So there is some within the higher structures of the abdomen as well, that free fluid. So let's look at here. So now if they're focusing on this abnormal area, do you see any movement within it?
I think I see some flickering.
Yeah, so you get concerned that there may be a heartbeat there as well. We'll zoom in or decrease the depth actually to make it more optimized, and you can see this some flickering or fluttering in there.
Yeah,
makes you
certainly
concerned.
more obvious.
And then we can confirm that, of course, or get an actual measurement with M-mode, which we've gone over before. We won't get into it too much, but this is cut off on our screen here, but it's a heart rate of 154. So we have this adnexal structure with fetal heart rate and a bunch of free fluid that you're definitely concerned for ectopic pregnancy.
Yep.
So one of the features here that kind of looks classic is what's called the bagel sign or the tubal ring sign. So you see here, if we freeze it, kind of looks like a bagel, right?
Yeah,
this
I can see
kind
that.
of thickened area here with a hole in it, and that's where the fetus develops in that hole. So we'll put a picture of that up here. And then, so that's what you want to differentiate between that and the corpus luteum. So the corpus luteum, you remember, is like what the follicle generally transforms into. So when the egg is released, the corpus luteum develops to produce progesterone to support the early pregnancy. Mm-hmm. And that can look similar, but it's not going to have these fetal parts in it. Definitely no heart rate associated with it. So our diagnosis that we have is a ruptured tubal ectopic pregnancy. Let's talk real quick about the beta HCG levels as well and the discriminatory zone. Say that you have a woman that comes in with a beta HCG of 900, right? And you do a transvaginal ultrasound and you don't see anything really. What does that tell you?
Not super surprising. With a beta HCG of 900, we're not quite in that discriminatory zone where we wouldn't necessarily expect to see anything. Not seeing anything on ultrasound at a beta of 900s to be expected.
Yeah. So it's just important to remember for that you should, if it's above the discriminatory zone, which is usually like 1500 to 3500-ish, you should see an intrauterine pregnancy. And if you don't, that means that there's something abnormal. Just because you don't see IUP yet, it just could be early. But it is important to recognize that you can still have an ectopic pregnancy even with a beta HCG below the discriminatory zone. So doing a thorough exam and evaluating for the adnexa to see if there's any adnexal masses and looking for free fluid is wise on every study, despite what the beta HCG may be. So in her case, remember that her beta HCG was 59,000, and we were saying that the dates didn't really add up, right? So that is concerning. It gives more support that this is an ectopic pregnancy, right? It's outside the uterus. And 59,000 is a level where if there was an intrauterine pregnancy, you definitely see it within the uterus.
I agree.
All right, so this is a tubal ectopic pregnancy. Some of the other locations that you can get ectopic pregnancy are called interstitial or cornual. You can have ovarian. You can have them on the cervix. You can have an ectopic pregnancy at the level of a cesarean scar, and then just free kind of floating within the abdomen as well. So this case, obviously the OBGYN was consulted, and what do you think they did with her? You think this is a methotrexate case or this is OR?
No, I think they probably took her to the operating room.
Yeah, that's exactly right. She had a bunch of hemoperitoneum, I think it was about 500 or so, with a tubal ectopic pregnancy that was removed. She had a self-injectomy. When do you use like methotrexate, and what are the kind of the contraindications for using methotrexate?
Yeah, I think the biggest thing for me is, are they a stable patient? So in this case, she was not, but if the patient was hemodynamically stable, if we don't see any evidence of rupture on ultrasound, I think that would be another reason we could use methotrexate. But the patient also needs to have good follow-up because we need to be able to track the beta HCG.
All right, John, we went through some great cases today. I just want you to give our viewers just one pearl that you want them to take away from each case.
So first we talked about an abscess versus something else. So my pearl from that case would be put color flow on it. I want to make sure that I'm actually cutting into an abscess and not like a pseudoaneurysm or some other sort of vascular structure that a color flow would indicate to me. Secondly, we talked about a cardiac tamponade case and a PEA arrest. I think what I learned, in addition to ultrasound being good for diagnosis, you can also use it for procedure. And in this case, it was life-saving, so pretty cool. In case 3, we talked about a bubble study as well as shunt physiology. And we saw how some bubbles, if you push through an IV line, will end up in the right atrium. But what's also important is the timing of that and to figure out where those bubbles go after the right atrium. If it comes pretty quickly and goes into the left atrium pretty quickly within the first few heartbeats, then there's probably some sort of septal wall defect, versus delayed, it's probably something more to do with the lungs. Case 4, we talked about a molar pregnancy. In that situation, you're seeing something that looks like grapes or a snowstorm that's within the uterus in the absence of any fetus. You should be thinking about a molar pregnancy, and like we talked about, there are some pretty significant downstream consequences to that, so being aware of that and treating it appropriately is important. And then lastly, talking about an ectopic pregnancy, pearl from this, if you don't see an IUP but the pregnancy test is positive, we have to look somewhere else for it. We know it's in the body somewhere, so we need to use the ultrasound to figure out where it is if it's not in the uterus.
All right, well, that is all for this episode. So remember, if you would like to submit a question to be answered on one of our podcasts, you can record an audio question at speakpipe.com/soundcheck. A big thank you to our co-host, Dr. Jon Giolitti, and to everyone who performed these great ultrasound cases. For more resources and a full list of all the episodes, you can visit mepsono.com or check us out on YouTube at youtube.com/MedStar Emergency Physicians. We'll be back next month with more great cases. So until then, go out and put these pearls into practice.